Welcome. My name is Jasmine Kamboj, and I am a medical oncologist and hematologist in the state of Minnesota and your host for the day. Empowering Oncologists is a podcast brought to you by OncoDaily, where we will focus on day-to-day concerns of an oncologist's being and workflow with a vision to find sustainable solutions. We hope to share our stories of wins, losses, resilience, and inspire and empower our community because we fly higher and longer when we fly together. Before we dive in, a disclaimer. The views shared on the podcast are in individuals and in no way are contributions from any institution, organization, or guidelines. For our session today, we have Dr. Miriam Mutebi, who is a consultant breast surgical oncologist and assistant professor in the Department of Surgery at the Aga Khan University Hospital in Nairobi, Kenya. She is the immediate past president of the African Organization for Research and Training in Cancer, also known as AORTIC, immediate past president for the Kenya Society of Hematology and Oncology, also known as KESHO, and is on the board of directors of the Union for International Cancer Control, UICC. When not working, she likes to read and has read 212 books last year. She always has a book with herself and is currently reading Death of the Author. She also does theatrics and is a huge fashionista, and we love her for that. Dr. Mutebi, welcome and thank you for being here.
Thank you for having me, Jasmine. I think I'm incredibly impressed, or I would say motivated by the ethos of empowering oncologists, because I think sometimes we think about oncology as clinical work, but really the empowerment really sits at the intersect of care delivery, policy, community engagement. And so there are all these different aspects that really go towards, empowering oncologists. So looking forward to a great conversation.
Yeah. Oh, thank you. Thank you so much, Miriam. Well, Miriam, you have been the president of the Kenya Society of Hematology Oncology. I have a few questions around that. First of all, tell us about your journey to becoming the president.
Oh, okay. Wow. I think in terms of getting to the presidency, I guess it's more, I would say, showing up and doing the work. KESHO has been around for quite a while, and I think immediately after I qualified as a breast surgeon, I was kind of looking for community and trying to see who might be who is available to provide support and insights. And of course, as you know, breast cancer surgery is always a team sport, so we're always looking around for where's the rest of the team. I can't operate without pathology, radiology. The oncologist is the medical oncologist is probably your best friend, followed by the radiation oncologist. And so it was really around trying to get into that community and showing up and volunteering. I think I started off as a treasurer for the society, and then kind of got gently nudged into being president. But I think it's just the bit around showing up and doing the work that actually goes a long way towards getting into some of these positions. It's not like a strategic sometimes orchestrated thing. Is this something that sometimes happens organically? Actually, most of the time it's organic, because you do work, you love it, you keep doing more, and we always joke and say no good deed goes unpunished. So you definitely have more work handed over, but I mean, it's a responsibility that is also, I think it's a measure of trust and responsibility, and it's not something to take lightly. So I think that's probably how I wandered into the presidency of KESHO, so to speak. Yeah.
That's beautifully said. And I so agree. The reward of doing the work with these societies is more work, but we happily do that because it's so rewarding, right?
I was just going to say it's pretty much reflective of, you know, how as oncologists we kind of get into the space. And like for me as a general surgeon, I'm sitting and we have to do, we used to have what we call end of rotationitis, because you get to do all these clinical specialities. You get to do urology, you get to do orthopedics, you get to do all these different things. And you're like, oh, I can do that. I can do that. But I mean, I was, you know, we had to rotate in the breast clinic, and, you know, I'm sitting on the clinic and kind of going at, you know, looking at the textbook description of a typical breast cancer patient. And, you know, at that point, he had a book called Bailey and Love, which is basically the surgical Bible, but it was like, you know, breast cancer is a disease of the 6th and 7th decade. And, you know, the poster child used to be, unfortunately, what we'd call the nulliparous nun, because, you know, never had children. They're basically having that uninterrupted estrogen. So never had children, you know, never pregnant, never breastfed, all of which is supposed to be protective, you know, factors. And you're sitting in clinic and you're like, hang on, my patients are in their 30s and 40s, you know, all have all these traditionally protective factors. So what's going on? And so that's how I kind of wandered into breast cancer surgery. But then again, I think it's a series of interactions and things, because sort of sitting down and again recognizing that once you've done you know, breast surgery, we're still recognizing that quite a number of our patients are, you know, getting diagnosed with advanced disease and not even completing their care. You're like, hang on, what's going on? And so that's why I'm like, oh, somebody needs to sort this out. So I like to joke and say I'm a, you know, cancer surgeon by day and a systems researcher by night. So I actually had to go back and, you know, just get my research training in clinical epidemiology and health systems research, just to try and understand, you know, why, what's happening, and how can we sort of design interventions that kind of talk to those barriers. But I think the biggest drive sometimes is actually patients. And we used to, I mean, I remember as a resident, we would have to sort of sit and support, go and give talks with the local, you know, breast cancer support groups, and they would have you know, very interesting stories and experiences, and you're like, oh no, this is unacceptable. I mean, one of the things I think that stood out for me specifically is I went to give a talk on complications of breast cancer surgery, and so I'm talking through, you know, you can get, you know, post mastectomy pain, you can you know, you can get infections, necrosis, and you know, I just typically, you know, giving a run along and saying, we're surgeon, we'll have talked to you about this and about that. And you're kind of sitting down and wondering, why is everybody, you know, you sometimes when you're giving a talk and you read the room and you're wondering, why is everybody looking deer in the headlights? Like, what's going on? And then later on, they came and told me, oh, you're, you know, talking about this fairy tale where, you know, somebody actually tells you what to expect. And one of the patients, I remember her because very feisty lady who's still in contact. She had this really bad lymphedema. And was almost double the size. She actually had DCIS, which again, if you think about it, doesn't really need an auxiliary clearance. But she was 65, and she said, you know, how her diagnosis was broken to her was, you know, she went in and she was told, you know, you have a cancer. We'll take you to theater tomorrow and chop off your breast since you clearly don't need it. And she was like, who says I don't need it? Right. And so it's really those bits and points around, you know, somebody needs to be a champion for our women. Somebody needs to ensure that the patient's voice remains central to the conversation is really why the drive towards breast cancer surgery, and also towards understanding barriers to access and really trying to design interventions that speak to them and stuff.
you bring up so many great points, Miriam, here, because it's so pivotal to have an informed decision with your patients, so patients can actually voice themselves in the decision making, because we're not doing justice to them if we're just kind of imposing our recommendation onto them, as opposed to having them partner in that decision making with us. That's very well said. Thank you for being a champion for all our patients in Africa. Thank you. So, circling back to KESHO, how many members do we have in KESHO? And in general, what's like the physician-patient ratio in Kenya for oncology versus patients? And it's okay if...
yeah. I would say KESHO probably has grown. I mean, we have probably a little over 100 oncologists, but when we think about that in context, Kenya is a country of about 54 million. So if you're doing the math, those are pretty drastic ratios to have. But I think one of the things that we recognize early, and I think this is a problem. This is a concern that's really across many parts of Africa in terms of the physician or health worker to patient ratio. How do we build community to threat? And so out of the gate, one of the key things that was a priority for us, at least the excellent team I was working with at the time when I became president, was really how do we expand our footprint beyond Kenya? And I think we also sort of caught the tail end of the COVID pandemic, and so we were really thinking about how do we create platforms for education and knowledge sharing. And what ended up happening is that we were able to really amplify our platform such that we went from, I think, 20, 30 patients, 20, 30 health practitioners on a webinar to about, we now have weekly webinars, usually at the peak having about 1,000 practitioners from across Africa. And so that was really huge in terms of building that community, because sometimes one can feel quite challenged, like maybe you're the only oncologist for miles, you feel like I'm isolated, but now we're really trying to harness that community, share, but again, we always joke and say breast surgeons have a one track mind. See, I was going to say best practice, but I automatically went to breast practice. But yeah, in terms of just trying to highlight, best practice and share ideas. And I think one of the other things that we were able to do was trying to evolve KESHO into a research active society. And so over that period, we were able to really harness our research committees to start to ask, and working in collaboration with the National Cancer Institute of Kenya, to really start to, generate data that, is applicable to our setting. And currently, what we at least maintain that. We're currently working on, I would say, quite a number of multi-sectoral or collaborative research. Part of the work that we've done recently has just been around the cancer survivorship experience in Kenya. And that has been in collaboration with KESHO, which is, of course, the Kenyan Society of Hematology and Oncology, but HENCO, which is the Kenya Networks on Cancer Organization, which is essentially the umbrella body for civil societies in Kenya. And I digress, but this is an important pivot, because KENCO, I think, is one of the models that we actually sort of try and amplify. So now that I have the floor, we can sort of at least give them their flowers a little bit. I think KENCO really came out of a pain point from civil society organizations where initially everybody wanted to engage, but everybody was looking at sort of what's the low-hanging fruit, and everybody was kind of doing advocacy around screening. And so we'd go in, screen, and then you're like, then what? And so civil society organizations took a step back and said, hang on, why don't we try and, really cover the entire continuum of care? And so we have different civil societies advocating for early diagnosis. We have different organizations really championing treatments. We have others looking at survivorship, and they've really evolved much and have been pretty powerful in the sense that currently in all the Ministry of Health technical working groups, we have representation from civil society and from people with lived experience, which is incredibly powerful in terms of ensuring that implementation policy and changes actually are, reflective of the opportunity sometimes, and maybe also trying to mitigate some of the bottleneck that patients do usually encounter in navigating us.
Yeah. So do you obviously like work closely with the Ministry of Health in your country then?
Yes. So the National Cancer Institute of Kenya is part of the Ministry of Health, and we work very closely as KESHO because, again, if we're going to implement, the ministry would like to implement practices and stuff, then they would need the professional society. So there's a lot of cohesiveness and overlap, and then we also have the National Cancer Control Program that has done incredible work in terms of providing trainings and education. And so we work collaboratively to ensure that we're sort of straddling the three pillars, whether it's from the society sort of level through the civil society organizations, the professionals, and then finally the policymakers. So it's a very integrated approach that really goes a long way in terms of making sure that, again, we used to joke and say Kenya is super rich in policy, but I think for a while there was a gap between the translation of that into action, but I think over the last 10 years, I would say props to our policymakers. There have been deliberate intentions and strides towards sort of implementing that, and there's been decentralization of health services. I'll speak from a breast cancer perspective, come up with a breast cancer action plan around early diagnosis and treatment, and really trying to define guidelines for our setting. So it's been, I would say, an inspiring time to kind of work together with both government, civil society, people with lived experience, just to make sure that we're getting more people through to the finish line in terms of their cancer journey and stuff.
Again, so many wonderful points. Like, policy doesn't make much sense unless it's put into some action and implemented, for the better of our patients and for the better of our people. And again, like your point of like going beyond Kenya and trying to integrate, other areas or other regions in your continent. I mean, that is spectacular. Thanks for doing all the great work, Miriam. Pivoting on to a little bit of a different topic. You, my friend, are the co-founder of the Pan-African Women's Association of Surgeons, which is centered around mentorship and leadership in women in surgery. Tell us what led you to founding that association and what is the kind of work you guys are doing there?
Sure. Thanks for the question. I think ours probably came about because I was feeling lonely. if I'll be completely honest, because I think by the time I did my general surgery, I think was the fourth female to do general surgery in Kenya. And keep in mind, our program has been running for the last 50 years. So women in surgery, I think, hasn't necessarily been an intuitive career choice. And so,
Mentor.
thinking, I think we were kind of sitting down and having a bit of a moan with one of my friends, and we're like, wouldn't it be nice to kind of, have a network where we sit and, well, of course, moan a little bit, but, do something positive about that. And so that's really how Powers came about. The thing that I think is particularly close to my heart around Powers is I think that, one, again, sort of going by the numbers, 9 out of 10 people don't have access to safe, timely, affordable surgery, and that's one. But if we look at where surgery is in terms of cancer care, we always call it the neglected stepchild of global health or global oncology because 80% of patients at some point in their treatment journey and in their cancer journey are going to require surgical services, right? And 2/3 of those might probably require multiple services, but I mean that's still a missing link. And so even from a policy perspective, sometimes we emphasize, and don't get me wrong, I love my, multidisciplinary team, but sometimes the focus is really on, building radiotherapy units, perhaps ensuring that you have access to systemic therapy, which is, extremely important for the multidisciplinary. But, if we do all that and you neglect surgery, which, to be completely candid is what, sometimes influences outcomes. You can do all this, give the patients excellent, chemo, really good radiotherapy, but you do really suboptimal surgery, you have done the patient an extreme disservice because the only thing that potentially have got the patient to cure is really having the best of all these different aspects. And so it's really trying to emphasize what are the aspects. I mean, how do we then elevate surgery in that perspective? The second is sometimes when we think about barriers to access, for women in our setting. I mean, of course, we sort of have the broad barriers that we all know about, the, financial barriers with women are having to pay out of pocket. Well, not just women, men and women having to pay out of pocket in order for them to access care. And that, results usually in, financial toxicity and perhaps, catastrophic health expenditure, but perhaps just because, again, women are the major workforce in Africa, but most of them are doing blue collar work. So sometimes they do not necessarily have the financial wherewithal to access care. And then, of course, we have the second, sort of broad bucket where we're talking about health systems barriers, where, patients on average, unfortunately, are seeing, based on our data, 4 to 6 healthcare providers before definitive diagnosis of their cancer is made. But one of the bits that we don't often talk about is the sociocultural barriers that exist. And we see this sometimes in the fact that in many settings, women are not necessarily the primary determinants of poor health-seeking behavior and may require, permission or some time, financial support or even permission in order for them to access care. But one of the things that perhaps we don't think about from a cultural context is the stigma or what is culturally appropriate. And so you would find that in quite a number of settings, women don't want people from the opposite, gender examining their breasts, for instance. And you may find that sometimes you get, grandmother coming in to the hospital and, she sees a doctor who's, her grandson's age, and she's reluctant to disclose that she has vaginal bleeding because it's taboo in that setting. And so I strongly feel that women have a unique role to play in the ecosystem in terms of mitigating some of these social cultural barriers, but of course also expanding the workforce. So it's not just a numbers game. Yes, of course, we would definitely love to increase the workforce. We know that about data from the last 10 years shows that out of about maybe 5,000, surgeons in West Africa, for instance, only 1% of those were female. But then that number is slowly starting to increase. And so we're like, hang on, if we can, get these ladies in, because it's not due to lack of interest, Jasmine. So you'd find that maybe a few people would enroll and then maybe get frustrated, drop out, or just because the idea of surgery didn't really occur to anyone. Right? And so we're like, if we can get out these ladies in, give them the skills for transformative leadership in whichever, ecosystem they're in, whether it's, surgeons, sometimes, I don't know, we always joke and say surgeons always end up getting the medical superintendent position for some reason. I don't know why. But if you do an average survey of who's running hospitals, and so like, it doesn't have to be that you're running a hospital, but even in your clinic, in practice, if we're able to equip you with the skills to really ensure that, patients feel seen, heard, and amplified, then, that's a win for the continent and a win for our patients. And so that was really the thinking behind it and stuff. And it's been a labor of love. It's one of those things that you go home and you're like, oh, let me try and do this and try and do that. But we're hoping at least over the next couple of years to really expand and scale some of the work that we're doing, so that we're able to have a more cohesive and I would say consistent.
Such great and fascinating points, Miriam. I'm so glad that you're taking the initiative to connect all these women, because I 100% agree with you. We are so isolated and stay in our silos that we all are feeling that, not just in Africa, but even in the States. We're all like isolated in our little clinics, and so we have to find a way to connect and really connect with each other, so that not only can we not feel isolated, but we can also advance each other personally and professionally for the good of our patients. And, like the theme of this podcast is that we fly higher and longer when we fly together. And that's exactly, in line with what you just said. So thank you for all the great work. You are the immediate past president of AORTIC. What was your biggest challenge and biggest reward of being the AORTIC president?
Ooh. I guess biggest challenge and biggest reward. Maybe it's actually a bit of both. In the sense that your biggest challenge is your biggest reward. But I think by the time we sort of stepped into leadership, I think AORTIC was, at that intersect of, both has a lot of promise, but also a bit of fragility. And so I think sort of going in, the priorities were around how do we re-anchor AORTIC, how do we engage our members, how do we become more member-facing, and also and how do we really step into our role as conveners of the oncology, the African oncology community, and then also sort of, drilling down to our tenets around, our vision is really around, how do we imagine, in Africa where everybody has access to safe, timely, portable cancer care. So one of the things that, again, we've sort of been known for our, I would say, education and training, and there's been a lot of work in that space. But I think, and of course, the research aspect of things. But I think one of the things that had been a little dormant and that you were sort of happy to revive was really around the advocacy. And so part of the work that we've developed over the last 2 years is really trying to empower our civil society, and really looking at how to talk to policymakers in a language that policymakers understand. And sometimes the especially with our civil society organizations, I think the tendency, because advocacy has pretty much, I would say, a nascent field in our setting, the tendency is to go and, we'll share your story, which is great, but that it doesn't necessarily move the needle. And so, training civil societies on how to leverage and use their stories to actually impact and motivate for change is one of the things that has been going. But I think really around one of the things was I would say, institutional renewal and trying to look at how to build systems and governance and trying to reconstitute our, council portfolios, giving people different roles and responsibilities, and really setting the framework for how we would like to operate over the next few years, and really shifting from, I think, one of the things that many organizations suffer from is, I would say, the fragility, especially when you have a 2-year reset button and everything sort of goes from the ground up. And so one of the things, in addition to, sort of strengthening the governance aspect of things, was really looking at how we're switching to a 4-year work plan, ensure that there's continuity of efforts and things. And so I think that's one of the things that, we're, I would say, incredibly proud about. Of course, it's hard work. It's not particularly glamorous, but I mean, those are kind of the, I would say, building blocks in order to have a solid, stable, sustainable system. And so those are some of the efforts that the undertook. And then in terms of really sort of stepping into our role, our convening role, of course, we've been known for our biennial conference, which is great, but then looking at how do we then, increase our member engagement from our convening capacity. And so we've had several regional meetings. The thing about AORTIC is, and I think the great thing about AORTIC is, it's really across the care continuum. So you have healthcare practitioners, you have the oncologists, you have the researchers, you have the policymakers, you have people with lived experience, you have civil society organizations. And so we have quite a number of special interest groups. And so really trying to revive that engagement with our communities, which involve having, setting up or curating several regional meetings, the town hall, really trying to create platforms for engagement, a better engagement, including revamping our website to make it more member-facing and user-friendly. And then I think really stepping into our role around the scientific content, because one of the things that I was particularly proud that we were able to do with my amazing, with support from the council, is really trying to create platforms for better dissemination of ideas. What we found, for instance, was that we'd go to this AORTIC conference, and I really urge you to come to the next one, because I would just say it's an experience. It's an experience because you're just sitting down and listening to all these incredible insights and minds and work that's going on, and there's so much energy. But then it's like, so much energy, and then hit pause, and then another 2 years, and then we do it all over again. And so it was thinking through, how do we then translate? I mean, it's nice if I'd gone to the conference, but then how do I then enhance those platforms? And so we've had quite a number of online engagement, whether it's through webinars, but also creating a forum for our members to actually disseminate ideas. And that was through the launch of the AORTIC Journal. And so we're hoping that beyond the sort of, publishing our local data, it's really the platform for best practice and knowledge sharing, but also capacity building in terms of mentorship and getting early career researchers to, again, ask the right questions and disseminate their results. And by early career, we were joking and saying, everybody in Africa is early career, because for the simple reason that, unfortunately, research is not something that's built into our training curriculums. And so what you find is people will have their first encounter with maybe research as a postgrad student for the first time doing a dissertation. And that might be the initial kind of exposure to that. And so in terms of building that capacity to ask questions that are relevant to the system. But beyond asking those questions, having the platform to disseminate those that data is also incredibly important. And we've had a long-standing grant mechanism in partnership with AACR and supported by NCI, who are actually the initial architects around the what we call the Big Cat, which is a Beginner's Catalytic Award, and that has really been one of the flagships that's um, been a constant in helping to support early career researchers and trying to answer questions in this setting. That's a kind of, I would say, considerable moderate grant, and that hasn't been necessarily because of funding purposes um, accessible to a number of people. But so one of the things we have to think about is we have this excellent product, but how do we get the person who's just fresh out of, you know, oncology training to ask questions in their clinics? And because we don't actually have that data, like what's happening to my patients, what are the outcomes? And that might not necessarily be in line with the Big Cat, which had been traditionally looking at basic science. And so what we launched is a micro grant, which the idea is to provide small food funding, and it's not anything dramatic. It's about 5,000 to 10,000, but really trying to answer these questions in different settings. And so empowering I would say the beginning researchers were beginning to ask these questions, build up a body of data that can help them become more competitive, whether it's for Big Cat or other sort of global grants, is really the thinking behind that. But then beyond that, thinking about how do we sort of create a community, because if I can answer the same question in North, East, West, Southern Africa, and I have a body of data that it could potentially use and interpret and that could have considerable implications from a continental perspective. And so that's really the thinking behind that. And I think just sort of stepping into our continental leadership role, I think I was incredibly pleased that we were able to develop new collaborations, revive old collaborations, but develop, I would say, new collaborations with a mixed bag, I would say, of partners, but all incredibly beneficial across the continuum. Whether leading the way, I think we had about over the last 2 years, we've been able to have some collaborations developed with 18 different organizations. But for me, I always say beyond the MOU, it's, you know, what is the work plan? How do we work together? And so we've, developed new collaborations with the WHO, IARC, with Africa CDC, with people like Encoder who are looking at oncology pharmacy and how to build capacity there. Looking at, I would say, POR, which is I would say, feeding the pipeline, which is really looking at medical students and how do we get them into and engaged with oncology. And so we were pleased that we were actually able to get medical students to attend the Tunisia 2025. And we now have a mentorship program where we're going to have a couple of medical students, 12 initially, rotating with us for 2 years, with the idea being that they get to have a flavor of the organization and get to hopefully let a spark in terms of getting them engaged and interested in oncology. And so those are some of the things that I would say
Very rewarding for you.
Yeah. And then I think, of course, also trying to as you said, from a systems level, just trying to go through and increasing our transparency and the accountability as an organization was also incredibly important to sustainability. So yeah, that's
Absolutely.
the thing that um, are the biggest joy. But as you can imagine, it's a
Yeah, a
double-edged
lot of
sword
work.
because it's a lot of
Yeah.
work. It's a lot of elbow grease, and so
Absolutely.
I think what I'm happiest about is that
Mm-hmm.
we're building for the future and not just immediate gains. And I think
Mm-hmm.
that for me, I think I don't know
Mm-hmm.
which there's a proverb, I don't know if it's African or whatever, where you're like, plant the
Uh-huh.
seeds for, trees whose shade,
Mm-hmm.
is going to provide shade for somebody
Right.
else. And so I think for us, it
Right.
was really trying to look beyond the immediate, that sort of have a long-term plan of how do we want the organization to grow? How do we want it to be amplified? I think is for me I would say the thing that we feel most passionate about. And of course, in terms of financial sustainability, we actually launched the our cancer foundation as a
Mm-hmm.
route, that route, depending on which side of the pond you're from,
Mm-hmm.
to really trying to ensure
Mm-hmm.
continuity in funding and sustainability of the organization. So all of those like different
Right.
I would say I like to call them like almost little ripples, but the idea is to have them coalesce in time and really
Mm-hmm.
have a tsunami of change is really what we're trying to build, and that's I think what I'm most proud of.
Oh, that's, yeah, so many wonderful, valuable points. Thanks for all the work you've done, Dr. Mutebi. I'm sure folks in Africa, both professionals and patients, really admire all that you've done. Thank you for all that. Miriam, your last question of the day. If you were to relive your life, would you become an oncologist or a surgeon just like you're doing all the great work? Would you still follow the same trajectory?
Um, I think so because um, how would I say? So when I was in undergrad, um, well, not
Mm-hmm.
in undergrad, sorry, in just out of high school, you kind of unfortunate, kind of like the
Mm-hmm.
end of rotationitis I was talking about. You have six different things that you kind of want to do,
Mm-hmm.
and I think I
Mm-hmm.
remember I wanted
Mm-hmm.
to do law, I wanted to do pharmacy,
Mm-hmm.
I wanted to write, I wanted to do
Right.
medicine. I even forget
Mm-hmm.
what the other things were, but
Mm-hmm.
then I think so. What happened was I went to my dad. Again, importance of good mentors and champions. I was like, Dad, I'm so confused. What I have six different things that I want to do. What do I do? And he was
Right.
like, why don't you spend a bit of time in each of these, areas and
Mm-hmm.
get a sense of what it is you'd like to do. And so
Mm-hmm.
I remember I went to work for a law firm. They actually let me stand behind the
Mm-hmm.
counter at the pharmacy and shadow the pharmacist in count pills. Ironically, I actually volunteered at the Aga Khan University Hospital,
Oh,
which is
very
where
nice.
I'm currently working. Yeah, and I think I actually spent some time at an architecture. And so by the time I think I
Mm-hmm.
had sort of narrowed it down to
Mm-hmm.
medicine and writing. I go back to my dad and I'm like,
Right.
Dad, what do I do? I have two things I want
Yeah.
to do. And my dad is like, well, if you do medicine, you can write,
Yeah.
right? But
Yeah.
if you write, you
Right.
might not necessarily do medicine. And so
For
I'm
sure.
thinking, if the stars kind of aligned, I would still probably follow the same trajectory. And I'm how would I say, we still use our writing for good now
Yeah.
in terms of whether it's policy
Oh,
briefs or lived experience or
yeah.
sharing our our research. It really moves the needle in terms of trying to get things forward. And just as a teaser, I still believe I have the
Mm.
next great African novel buried in here somewhere. So watch this space. So
That's funny. Well, thank you so much, Dr. Mutebi. That was our last question of the day. I do want to share the very meaningful new training that you're pursuing for our audiences. Dr. Mutebi is actually currently pursuing a pilot's license so she can actually extend her breast care programs and services to marginalized areas in Africa. And another fun fact about Dr. Mutebi is that she actually runs a food blog called Indolent Cook on Instagram. So don't forget to check that out, folks. All right, beautiful. So the three key takeaways for the oncology community from our conversation today. I really enjoyed how Dr. Mutebi's conversation revolved around the theme of engagement, advocacy, and community. And when we put all of this together, the outlying theme is empowerment. And it seems like that's her goal of life and purpose of life and her calling. And everything she's doing is somewhere or the other centered around these things. And I want to take the statement that she said. I don't think I've ever heard this said more beautifully than this, Miriam, when she said, as an AORTIC president, we are really trying to build Africa where everyone has safe and timely access to care. Because we can have all the access of care, but if it's not safe or timely, I think we lose the essence of it. And that she's trying to build the future for Africa and not just, take care of the immediate short-term tasks, but actually trying to really create a value-based future for her continent. So the three key takeaways: showing up and doing the work. There is no substitute for that, folks. That's how you start. That's how you start your career, and going that extra mile and showing up for, your societies and your community. I think there's no substitute for that. Number two, any research question starts with curiosity and interactions. So don't undermine your curiosity around your patients and interactions with your patients and colleagues. I think that's pivotal to answering any scientific question. And last but not the least, oncology is way beyond clinical care at this point. It's community engagement, it's care delivery, it's building a support system. And last but not the least, all of this has to be centered around the patient's voices. Patients are the center of everything that we do, folks. As all of our callings is centered around our patients. So that is all for today, folks. Thank you to our viewers and listeners. This is Jasmine Kamboj and Dr. Miriam Mutebi signing off on behalf of OncoDaily from our conversation on Empowering Oncologists. And now we have the Empowering Oncologist playlist on YouTube. Don't miss an episode and stay tuned. Thank you so much, Dr. Mutebi. Thank you so much.
Don't forget to like, comment, share, and subscribe to OncoDaily on YouTube. Hit the bell icon to stay updated.